10-hour-old boy admitted to the neonatal intensive care unit because of abdominal distension. The infant was born full term, weighing 6.6 pounds to a G1P1 mother by spontaneous vaginal delivery, no fetal distress. Pregnancy was complicated by polyhydramnios. Physical exam revealed upper abdominal fullness. Infant was doing well without any respiratory distress. So, differential diagnosis. We have a newborn that comes in with abdominal distension and vomiting. What are the things that pop up on your differential, things that you want to kind of rule out or rule in? Right. Mm-hmm. Okay. Definitely would lead to that vomiting. Yep. And so, really, anytime we have some sort of obstruction in the GI tract, that is ultimately going to lead to some distension, right, and some vomiting. So other things that we could look for are pyloric stenosis, right? When we have that kind of growth at the pylorus, babies start doing the projectile vomiting, right? The olive mass. Yes. Mm-hmm. Yeah, and so you hope that they put that in there for you. But there's one other thing about pyloric stenosis that would rule it out for this particular patient. The age. So here we have a 10-hour-old boy. So this is right after birth. Pyloric stenosis typically doesn't manifest until almost 2-3 weeks after the baby is born. Okay? So it's more likely some sort of obstruction. Excellent, yes. Now, one other thing that we can think about, so what is in terms of what is causing this obstruction, you can think of some kind of like meconium ileus, and all of these things can pop up on your differential, but they've told us that the pregnancy was complicated by polyhydramnios. So what is the connection there? What is the connection between this newborn with abdominal distension, possibly an obstruction, and polyhydramnios? Mm-hmm. So let me ask you this. Where does amniotic fluid come from? What is like it comes from the amniotic sac. The fetus actually generates the amniotic fluid, right? The job of the kidneys as the baby's developing is to basically generate amniotic fluid, and the baby urinates it out. So baby is basically swimming in his own pee, right? Yeah. Yeah, it's pretty gross, but it's still so cute. So baby's in all of this amniotic fluid, and then the baby is going to open his mouth or her mouth and swallow the amniotic fluid. That amniotic fluid is going to get resorbed into the baby as it goes through the GI tract, and it's essentially going to keep the baby hydrated sort of from the inside, okay? And so this is the life cycle of the amniotic fluid. It gets peed out, it's all around the baby, surrounding the baby, and then the baby swallows it. It gets peed out, and that's sort of the life cycle. So what would happen if we had an obstruction in the GI tract? What would happen to this life cycle of the amniotic fluid? Excellent. Yes. We would have buildup of the fluid externally because the baby may be swallowing it, but some obstruction downstream is preventing it from getting resorbed. Okay, so we kind of have a backup of fluid, and that is what's going to cause polyhydramnios. So anytime you see polyhydramnios, I want you to think of something being wrong with the baby's ability to swallow, so the anatomy where the amniotic fluid is going down through the esophagus to the GI tract. Somewhere in there, something is wrong. Okay, so when you think about babies that have their central nervous system doesn't fully develop, anencephaly, those patients or those babies are going to have polyhydramnios. When you think about babies that have a tracheoesophageal fistula, where the esophagus ends in a pouch, rather than being connected to the stomach, that baby is going to have polyhydramnios because the amniotic fluid can't get to the stomach. And in this particular case, because we have this abdominal distension, we can think of an obstruction a little bit further down. We can assume that the amniotic fluid is getting into the mouth, getting to the esophagus, getting to the stomach, getting to the duodenum, and maybe kind of getting obstructed there. Okay? And so, next best step, how could we, what's sort of the best tool we have to evaluate this in a neonate? Ultrasound, yep. Ultrasound is great. You'll also see x-rays done on babies if they have this, but obviously not the best thing to do, a x-ray on a baby, but ultrasound is really just as good for evaluating this, okay? So if we did do an x-ray, what we would see is a very specific sign that we look for, and this is called a double bubble sign. So you can see this one labeled 1 is bubble number 1, and then 2 is going to be bubble number 2. What we're looking at here is the fact that we have a distension of the stomach. Okay, so this is all of our stomach. It's very distended in this neonate. And then we have the pylorus, which causes this narrowing. And then we have a distension of the proximal duodenum. And then there's nothing below that. Right? We don't see any air, any fluid, anything below the duodenum. And so if we see this sign, what we call this is duodenal atresia. Essentially what's happened is the development of the duodenum stopped about halfway through, and while the rest of the GI tract may be fine, you may have an ileum, jejunum, small bowel, the large colon should be fine, the rectum should be fine. You have basically an area of the duodenum that did not develop fully. Okay? Great. So most likely diagnosis is going to be our duodenal atresia. The reason for this is an incomplete recanalization of the duodenum. Essentially what happens is that as the embryo is developing, initially it has a full GI tract. That GI tract kind of closes off as it starts to break down, differentiate into our upper GI tract, lower GI tract, our esophagus. And then it's supposed to open back up. During weeks 8 through 10, it doesn't do that, and that's what causes duodenal atresia. And one important aspect is that when you have a patient with duodenal atresia, about 50% of the time, you're going to see some other malformations, maybe a cardiac, renal, vertebral, and there's a very strong association with Down syndrome, okay? So if they've given that to you in the history, that your patient has Down syndrome, that may be helpful as well in terms of identifying this GI lesion. In terms of symptoms, we're going to look for gastric distension, vomiting, which may or may not be bilious, and this is going to be within a few hours of the first feeding. And so when we talk about our differential diagnosis for a neonate who presents with abdominal distension, keep in mind, when does this occur? How old is the baby? Vomiting in a 2-3 week old is going to be a little bit different of a differential from vomiting in an 8-hour-old. Okay, great. So postnatally, we can diagnose this using the ultrasound or an abdominal x-ray. Not the best choice. Ultrasound is way better. Atresias also are often detected during that prenatal ultrasound exam. They're going to see the polyhydramnios. That's one of the things that they look for on those prenatal ultrasound exams. So as soon as they see that, they're going to start looking for the reason why. Okay, is it because of an the tracheoesophageal fistula? Is it because of some brainstem abnormality? Is it this duodenal atresia? Okay. So surgical optimization, we need to get the neonate ready for surgery, and then we can surgically correct this. In the meantime, your patient should be NPO. We're going to place an NG or OG tube. Correct any electrolyte abnormalities, start broad spectrum antibiotics, and then we can go ahead and do the surgery. Okay, and so just sort of looking at how it looks on ultrasound, this is our double bubble sign that we see on ultrasound, where part of the stomach and part of the duodenum are both distended, and that's about it. Okay, questions on this one? Any questions? No? Okay, great. So sort of high yield points, everything we talked about, incomplete recanalization, strong association with other malformations as well as Down syndrome, gastric distension and vomiting, and then, we want to use ultrasound as the best, and then surgically correcting is going to be important down the line. Great. Okay, our next case here. We have a 4-year-old named Jasmine who presents to the office with a complaint of abdominal pain for 2 days. Her mother states that Jasmine's pain is intermittent, coming and going, and is mainly on the left side of the abdomen. She states the pain is sometimes worse after eating and that the pain is sometimes relieved by passing gas. Jasmine is unable to describe the quality of the pain, but her mother reports she sometimes doubles over in pain. Denies vomiting or diarrhea, has not had cough or runny nose. Jasmine's nutrition history reveals that she eats bananas and rice almost daily, drinks 4 to 5 cups of whole milk daily. On physical exam, normal active bowel sounds are present throughout the abdomen. Abdomen is soft and mildly tender in the lower left quadrant. Okay. Mm-hmm. 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 So, right, exactly, yeah. So that's an important thing too. But just to kind of clarify what you mentioned with an air pocket. So you're essentially saying that air is not able to escape, or. Mm-hmm. 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 Okay, great. Okay, good. So, in terms of a differential, we're thinking. Sorry, what? Uh-huh. Acute abdomen. Okay. Okay, great. So we have, some of the things that we want to take from this clinical history. The pain has been going on for 2 days. It's really localized to one side. It's made worse after eating, but passing gas makes it better. And otherwise, any thoughts on this nutrition history? Bananas and rice and lots of whole milk. Mm-hmm. Mm-hmm. It could just be constipation, yeah. Yeah, definitely. Definitely all the things that we're seeing in the history. Also, the fact that they're even mentioning the nutrition history here should definitely, sort of put us on high alert for thinking that it's just something nutritional that is a problem. Okay, great. So, oh no, they will definitely have fillers. Yes, you're right. They will definitely have fillers, but keep an eye when it's something really strange that you've not seen before. You want to double check and see, okay, is this something that I really need to know or not? And the way that we're going through this in sort of the case format, this is not how a question is necessarily going to look, being this verbose. But just sort of the things that you want to look for in a question stem. If you're thinking about constipation, and then they mention the nutrition history, that should be something that you really focus in on. Yeah. Great. So, next step in determining the diagnosis. Mm-hmm. Okay. Yep. But we want to see her stool. We want to see if there's something abnormal there. Okay. And so we give our patient, the cup to put a stool sample. We send them home and say, come back tomorrow with a stool sample. They come back tomorrow and they say, oh, we haven't been able to, she still hasn't gone to the bathroom. So. And they would respond, it's been about a week. Imaging. Okay, I like that. I like imaging, but it's hard, when you're talking about 4-year-olds, these parents are very resistant. They may not want to do imaging. Is there another thing you can do in the office, even just part of your physical exam, to try and evaluate this patient? Abdominal, yep, and you do a DRE, right? Your direct rectal exam. And that can, if you do the DRE and you see stool right there, then that, you're very suspicious at that point that it is constipation, just sort of physiological constipation. Okay, good. So now that we've decided this is constipation, we did our DRE. Yep, this girl has a significant stool load. We did the x-ray. The parent agreed to do the x-ray, and we could see on the x-ray that there's a lot of stool in the colon. So what is our treatment strategy going to be? How do we approach this? Wonderful. Uh-huh. Okay. Okay, good. And so I love everything you said. Start with the non-pharmacological. Get this girl to drink a lot of water. Get her to spend time on the toilet, because when it's this sort of toilet training time. I know 4-year-old is hopefully you've been potty trained by that time, but around this time, sometimes the constipation may not be to anything you're necessarily doing, but it may just be sort of fear on the part of the child, right? Or discomfort with using the bathroom, using the toilet. And so, some of those behavioral type of things are things that you can talk about with the parent as well. Okay, excellent. But like you said, lots of activity, lots of water. And if it's not resolving from that, we can start talking about using some sort of laxative, stool softener. Yep, excellent. Great. So just sort of big picture, differential diagnosis for abdominal pain is going to be a lot. When we talk about abdominal pain in kids, you can have functional dyspepsia, functional constipation, irritable bowel syndrome, cyclic vomiting, and abdominal migraine even, functional abdominal pain syndrome. The list goes on and on. This is a very short list of abdominal pain, but the differential is wide. Things that we really consider a red flag and we would want to get imaging right away. If we see pain that occurs at night and awakens the child, okay, that is very concerning. Pain that's distant from the umbilicus, accompanied by fever, dysuria, hematuria, joint pain and swelling. We think of maybe some sort of bacterial infection that's gone from the GI tract, and this patient may be close to becoming septic. Significant vomiting. We're worried about hypovolemia and dehydration. A change in bowel movement habits, weight loss, failure to thrive or slow growth. These are all of our red flags, and this is where we're going to want to get labs. We want to do imaging. We want to maybe start antibiotics depending on the cause. So those are things that really concern us. The patient in our question stem didn't really have any of these, so those red flags can kind of go away. When it comes to constipation, other things that you can think of, whether there's abdominal pain or not, think about cystic fibrosis. Okay, and so in cystic fibrosis, typically it'll present very early. This is going to be a neonate who fails to pass meconium within 48 hours. Okay, they're going to end up with very, very thick meconium, and so it's going to kind of sit there and may even cause an obstruction for your cystic fibrosis patients. Some neurological dysfunction, hypothyroidism. We want to rule all these out if constipation does not respond to our standard interventions. Okay, so what are those standard interventions going to be? Functional and caprices, functional constipation. There's a criteria called the Rome 4 criteria for functional constipation. And these are the criteria: a history of withholding stool, history of painful, hard bowel movements, large diameter stools that may even obstruct the toilet, presence of a large fecal mass in the rectum, which is something that we could see on direct rectal exam when the patient's in our office. 2 or fewer defecations in toilet per week. This is going to be something that they may give you in the question stem, where they say, oh, my child only goes to the bathroom twice per week. And, sort of, when you think about twice per week, it's like, I guess that could be normal. By the criteria, if you see this, where they're only going twice per week, and then any of these other facts, that's going to give you the diagnosis of functional constipation. Okay? At least one episode of fecal incontinence per week. What's happening with fecal incontinence is that as the stool load, if we have our bowel here, so this is our descending bowel, and we have this hard impacted stool here. Very, very thick, hard stool. What's happening is upstream of this stool, we may have some fluid that leaks out around the hard impacted stool, and our child is going to end up having fecal incontinence due to this fluid that's sort of leaking by the hard impacted stool. This doesn't tell us that that hard impacted stool is now progressing forward. Unfortunately, these patients with fecal incontinence can go on for months and months and months with this stool burden and just having fecal incontinence. Okay, so we definitely need to figure out what's going on. If we have any of those red flags we talked about, we can jump right to the plain film x-ray to check for retained stool. Otherwise, with the clinical history and that direct rectal exam, we're able to make our diagnosis and implement some of our treatment strategies. Okay, and so initial treatment, we need to clean out the bowel by any means, orally or rectally. So we can do enemas, osmotic laxatives, stimulant laxatives, polyethylene glycol. This is probably going to be one of our better treatment options for kids, especially if you see kids with recurrence. Okay. And when you talk about medical management, polyethylene glycol is going to be a very useful strategy. What it's going to do is it's essentially going to draw a lot of fluid out of the wall of the colon and into that hard impacted fecal mass and kind of get things moving. Okay. Dietary wise, low fat, high fiber diet, like you told me earlier, a regular exercise, and then this milk intake piece is something that I see again and again in the literature. We want to see less than 24 ounces per day. A lot of parents give their kids a lot of milk, and this can lead to constipation, and so we want to decrease that milk intake. Diets that are high in potassium, we also get concerned about constipation. And so, kind of limiting, I think in the question stem it said something about eating a lot of bananas. We kind of want to limit that as well. Lifestyle changes, scheduled toileting. And so, when you have a child, you believe they're toilet trained, but then they start having this constipation, they may not be fully potty trained after all. And so using some of these methods of potty training, such as scheduled toileting, where the parents are spending dedicated time with their child on the toilet, waiting for them to go, can help to sort of, if there's any emotional, psychological aspect to toileting that's causing this constipation, we can kind of alleviate that as well. And that's not going to be for every child, but it's not something we want to leave out, especially in terms of educating our families. Okay? Right. Yeah, absolutely. The fact that, that it's being brought up, in previous courses, and then something that I've sort of read in the literature, I really think that's going to be something that they, want you to be comfortable with when you take the exam, is that this behavioral aspect can play a big role in terms of treatment. Yeah, very good. Very good. Any questions on encopresis? No? Okay, great. Next, we have a 8-month-old boy, no significant past medical history, presents to his pediatrician with irritability and 1 episode of stool mixed with blood and mucus. Okay, so just based off that first line, we're going to start to build our differential. What are some of the things that, this is very alarming. What are some of the things that pop to your mind? Good. That's absolutely what you should be thinking of. At this point, we don't have any more information, but when you're thinking of a child and you see this current jelly stool, you really want to think of intussusception. So let's go on from here. The mother notes that he began crying inconsolably for about 30 minutes after waking up early from his morning nap, then began acting like himself again. An hour later, he began crying again and was noted to be pulling his knees toward his abdomen. Continued to have episodes of irritability and crying that lasted about 20 minutes and occurred at 30 to 45 minute intervals. And so, no, that's okay. On examination, he is afebrile, vital signs are within normal limits, rectal tone, and FOBT positive stool. So, most likely diagnosis. Has anything changed your thinking? Excellent, yes. Yeah, well said. That hypoxemia in the wall of the GI tract is what's leading to all that pain. And as, through the GI tract, we have this peristalsis where every about 20, 35 minutes, we're going to have movement of the wall of the GI tract. So every time we have that peristaltic wave reach this intussusception, the patient's going to have the symptoms. And then once that wave ends, the patient's going to go back to normal. Very typical of intussusception. Very good. What do we expect to see on physical exam? What are some of the signs of intussusception? We already nailed our diagnosis. I'm giving it to you. So what are some of the things that they can sort of throw at you in question stems, things that they can give you as answer choices that they want you to know? Good. Yep. Yeah. So it's absolutely possible to see distension. Not really, because it's such an acute thing, there's usually not time for distension to kind of manifest, right? We need to have a buildup of something upstream to cause that distension, but that is certainly possible. I would definitely not say it's impossible. That's something that you could see. Specifically, well, what we're really looking for is we have a piece of bowel that's telescoped inside of another piece of bowel. That is going to be palpable. And so you'll hear it described as a sausage-shaped mass or any type of mass, and that's typically going to be in the right upper quadrant. Okay. The reason that we see it in the right upper quadrant is because the area that tends to be involved in intussusception, so I'm drawing our colon here, and so here's our terminal ileum, here's the cecum, and here's our ascending colon. Intussusception tends to involve the ileum being pulled upwards into the ascending colon. Okay, and so now that we've intussuscept this whole area, what we see is that we have essentially what looks like this. And here's our cecum, here's our terminal ileum, and here's our transverse colon, and it's coming off to the side here. Here's our small bowel, okay? And so we've had this area of terminal ileum comes up into the ascending colon, and so what we will feel is that in the right upper quadrant, we will have this feeling of some sort of mass there, and then in the right lower quadrant, it should feel a little empty, okay? And that's just because that part of the bowel has sort of been sucked up into the other part. Great. So, best diagnostic test. Ultrasound. I like it. Yep. And what is the classic sign that we can see on ultrasound? This is a bonus question. Don't worry if you don't know it. Yeah. 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 Exactly, yeah. So you can see sort of the larger part and then the part that's telescoped inside. And what they call this is a bullseye sign. You may also hear it called a donut sign. There's like 5 or 6 different names for this, which is why I'm not surprised that it didn't pop right into your mind. But essentially what you're looking for is just that part of bowel that's inside of the other part of bowel. And we'll look at a picture. Yeah. Great. So intussusception, most common cause of bowel obstruction in the first 2 years of life. Involves a portion containing a lead point telescoping into adjacent bowel, and different pathologies are associated with intussusception for different reasons, depending on what the lead point is. The way that I like to think about the lead point is that it's an enlarged lymph node, and that's because the most common cause of intussusception in this age group is going to be some sort of gastritis, some sort of viral infection, okay? And so, your viral colitis, viral gastritis, you have that inflammation in your colon secondary to a virus, the lymph nodes get larger, and then they sort of act as that lead point to pull the terminal ileum up into the large bowel, okay? But there's other ways to get it. So in cystic fibrosis, you can get a bit of stool that acts as a lead point. Henoch-Schönlein purpura is a type of vasculitis where you can have a lot of bleeding into areas, including the bowel wall. And there you would see a hematoma acting as a lead point. Meckel's diverticulum. What is a Meckel's diverticulum? Meckel's diverticulum is essentially our example of a true diverticula. And so what happens is during embryogenesis, we have this duct called the vitelline duct that goes from about the near the end of the ileum, and it essentially provides the growing baby with some nutrition from the mother, from the placenta. If that part of the embryo does not degenerate, it gets left behind, and so when the baby's born with this little bit of tissue that involves pancreatic tissue and stomach tissue, basically a whole bunch of different little bits of tissue, and it's connected to the area of the ileum. That diverticulum can act as a lead point and pull the bowel around. Okay. Parasites can cause this, obviously very uncommon. The most common that you would see in this age group is going to be secondary to adenovirus or some other preceding gastroenteritis. Some other typically viral, could be also bacterial inflammation of the gastrointestinal tract leads to the intussusception. So that may be given to you as part of the history. If you have a patient that's over 6, please keep small bowel lymphoma as part of your differential. Okay. So we talked about what the most common symptoms are: the sudden onset, severe progressive abdominal pain, the crying, drawing the legs to the chest, seeing that current jelly stool, and then we may feel the mass on physical exam. Abdominal x-ray may show the obstruction, distended loops of bowel, lack of air in the right lower quadrant because there's no more bowel there. Our abdominal ultrasound, highly sensitive and specific. We're looking for that bullseye lesion, and this is really going to be our go-to test on the exam. The other test that we need to know is our barium enema. What's nice about our barium enema is we will be able to see the intussusception using this dye, and using this dye, we'll also be able to reduce the intussusception. We'll be able to force that bit of bowel out and essentially cure our patient here. So the recurrence is going to be uncommon for patients with intussusception. Yeah, it is. So here's our bullseye lesion. This is an ultrasound, right? And so you can see sort of the layers of the bowel wall sort of folding in on each other. Yeah. Mm-hmm. Yep. You just use a little bit of that enema. They use air plus that barium dye, and they just basically distend the colon until it pushes out. Yeah. Great. Excellent. So sort of a review of high yield points. Most common cause of bowel obstruction. We're looking for a lead point. The symptoms you told me already you're very comfortable with, which is good. Abdominal ultrasound, sensitive and specific. Barium enema, diagnostic and therapeutic. Very helpful. Great. All right. So next, we have a 6-day-old girl born at 35 weeks gestation being evaluated because of a 24-hour history of abdominal distension, decreased feeding, and vomiting. Okay. So what do we think with a 6-day-old girl born a little early, 35 weeks, with all of these symptoms? Okay, we'll put GERD up here. Okay. Do you like our duodenal atresia, the one we already talked about? Do you like that for this patient or no? It's possible. It's definitely possible. What is there anything that would move it up or down your differential? Not yet. We'll just leave it up here. Duodenal atresia. Okay, great. So this baby girl was born via induced vaginal delivery to a 26-year-old G2P2 with preeclampsia. She was stabilized in the NICU and has been doing well. No signs of respiratory distress. However, over the past day, she has gradually become more irritable and has been vomiting her formula. The last stool she passed was guaiac positive. The nurse also describes one episode where she stopped breathing. On examination, she is lethargic and lying still. Temperature is 100.1, heart rate 145, blood pressure 91/60, respiratory rate is 20. Birth weight was 2 pounds 8 ounces, and her current weight is 2 pounds 6 ounces. Abdomen is distended, tender to palpation, with decreased bowel sounds. So, is there anything else that's popping up on your differential? Things you'd like to remove? Okay, good. I agree. Mm-hmm. Absolutely. Yeah, I think so. I believe 145 is normal, yeah. Uh-huh. I always have to look these up because the blood pressures are so wonky for neonates, yeah. Mm-hmm. Mm-hmm. Aw, your baby. Uh-huh. Mm-hmm. So you're definitely headed in the right track. So you said that there's probably an infection because we see that she's febrile. I agree 100%. I went ahead and looked up blood pressure. She is a little bit low. She is a little bit low, her blood pressure. And then we're thinking something with the GI tract because she's tender to palpation, it's distended, decreased bowel sounds. And then what do you think about this guaiac positive stool? Guaiac positive is essentially our FOBT, same thing. Mm-hmm. Yes, exactly. Great. So we have blood in the stool. We have signs of an infection, a tender, distended abdomen. What do we think is going on? She absolutely she has some sort of infection. Yeah, some sort of infection in her GI tract, right? Mm-hmm. Mm-hmm. Good. So, some of the things that we consider in patients such as this one. So, patients that are born at 35 weeks, any preemies, some of the things that we think about respiratory distress, right? Because they don't have enough surfactant, they can end up in neonatal RDS, and so that's one of the things we think about with preemies. That's sort of our respiratory thing. And yes, this patient stopped breathing, but otherwise, there's not really a lot of respiratory symptoms, right? So we don't think that it's ARDS or NRDS. The other consideration that we have for babies born early is the how ready their GI tract is to take in formula. Because part of the last few weeks of development is some of the vasculature growing into the wall of the GI tract. What can happen sometimes in premature babies is that vasculature hasn't fully developed. And so if these babies are introduced to formula, for example, too early, what can end up happening is as that GI tract is trying to process all the formula, it's not getting enough blood supply while it's trying to, absorb all of these nutrients, this very nutrient-dense formula. All these cells are working at top speed. They're not getting enough blood supply because that vasculature hasn't developed. Now part of the GI tract is going to become ischemic. Okay? This is a concern, again, with our premature babies. Part of the GI tract comes ischemic. Now that part of the GI tract dies. Okay, not good. So this is going to give us our guaiac positive stool. We have part of the GI tract that has basically necrosed and died, and we're having a little bit of blood in the stool. Now we have all of this dead tissue in this area. Bacteria can come in and really manifest a nice infection. That's what they like to do. They have all of this, necrotic material. They're going to manifest an infection there. And so this particular condition is called necrotizing enterocolitis. And this is one of the reasons that is very common in premature infants. Well, not very common, but it's most common in premature infants. And it's caused by having that bowel ischemia with a bacterial invasion of the bowel wall on top. Okay? And so this is one of our concerns about advancing the diet of premature infants, is their GI tract ready to be taking in this nutrient-dense diet? Okay. Some of the symptoms: temperature instability, lethargy, apnea, the bloody stool, abdominal distension. The way that we diagnose this is we're actually going to go straight to X-ray. If we're suspecting necrotizing enterocolitis, yes, it's a preemie, but we still want to get that X-ray to be able to see whether or not this baby's abdomen has perforated. And so pneumatosis intestinalis means we're having air in the wall of bowel, and that will tell us that there's a bacterial infection there. Air in the portal vein, free air under the diaphragm means that this baby has had a perforation of their GI tract, and we need to take that baby to surgery. If there's no perforation, we can do bowel rest, NPO, NG tube, IV fluids, antibiotics, and we will have to put this baby on TPN. Okay, this baby will have to be getting all of its nutrition through an IV because it's obviously the GI tract is not ready or fully developed to take in high nutrient-dense meals. Okay. Yeah. Typically, we have a very high degree of suspicion of this happening again. And so we would wait, 2-3 weeks on TPN and then slowly start formula. The biggest problem is if you give a tiny bit of formula that's more diluted, this baby might have been fine. It's really when you give a very nutrient dense, where the GI tract is going to be really actively trying to absorb all this stuff and not getting enough oxygen and now necrosing, that's where you're having the problem. Okay. Breast milk wouldn't make any difference. Still pretty nutrient dense, yeah. Okay, and so in terms of life-threatening problems for preemies, think about your neonatal respiratory distress syndrome due to lack of surfactant, and lack of lung maturation, and then think of necrotizing enterocolitis as anything in the GI tract with a preemie who is now sort of in a very acute state. Okay. Great. Any questions on necrotizing enterocolitis before we move on to our next case? No? Okay, great. So next, our peds GI. We have a 3-day-old boy brought to the pediatrician by his mother, who's worried that her son is turning progressively yellow. He was born by spontaneous vaginal delivery at 36 weeks to a 25-year-old G1P1. She had good prenatal care. There were few complications with the pregnancy. He was discharged from the newborn nursery at 30 hours, has been breastfeeding and stooling well. On examination, he is a well-appearing infant with marked jaundice over his face and torso. So, great. Yeah, absolutely. I 100% agree. Hyperbilirubinemia, this kid's got jaundice. The bilirubins are probably going crazy right now. So that brings us into the whole category of all of the different causes. And so considering this patient's history and considering how old the patient is are sort of our two ways of determining what that cause of hyperbilirubinemia is. Okay? And so considering this patient, what are some of the causes of hyperbilirubinemia that you would want to rule out or that you think would probably be the most likely diagnosis? Mm-hmm. Mm-hmm. Yep, absolutely. So something to do with the baby's, eating. Is the baby eating enough? Is the baby stooling enough? Like you said, seems like the baby's eating and stooling well, so we can rule that as a potential cause. And it's good. It's good that this is popping into your mind, because this is going to be an answer choice. If you can rule it out, you just increase your chances of getting that answer right. Right. So that is fine. Other causes, we could have some genetic, a mutation in the enzymes that process bilirubin. But, for a baby, this baby's already 3 days old and, has been breastfeeding and stooling well. We really don't think about, that being the potential cause, because we probably would have seen some of that bilirubin when the baby was born, right? In the first 24 hours. So in terms of all those enzyme type problems, we can kind of rule those out as well. And so for a baby that's 3 days old, is very healthy, other than being, glowing in the dark, our typical cause is really just going to be a physiologic breastfeeding jaundice. And so the two types of physiological jaundice is we can have a breastfeeding jaundice and a breast milk jaundice. In breastfeeding jaundice, what happens is you have a baby who is not feeding enough and not drinking enough, breast milk or formula or what have you. Because they're not drinking enough, they don't have enough of the intermediaries that they need to break down bilirubin, and they end up becoming jaundice, okay? This baby happens to be breastfeeding well, so we can say that this is probably going to be a breast milk jaundice. Breast milk jaundice is due to some of the lipids and proteins that are inside of the breast milk. They actually inhibit the breakdown of hemoglobin into bilirubin, and bilirubin to be conjugated and then leave the system. So breast milk jaundice is due to the milk proteins and lipids in the breast milk. Okay? And so because we know that this baby is breastfeeding and stooling well, we think probably the diagnosis is going to be our breast milk jaundice. Okay? Exactly. Exactly, yes. So the baby's getting enough milk, the milk came in fine, but the proteins in the milk are causing this jaundice. This is a jaundice that's going to go away within a week, and really we don't need to do any treatment. For breastfeeding jaundice, that would be the mother that you just described, a mother whose milk has not come in, and the baby's not getting enough nutrition, not getting enough formula or what have you. Okay, so for breastfeeding jaundice, we have decreased nutrition. Okay, and we'll. Nope, this patient, no, we would not. Just from the description here, I would not think that we need those UV lights. However, the exact determination of whether or not we need UV lights is by the bilirubin levels. Okay, and they didn't give it to us, right? So that makes it much harder to determine. But the first thing we would do is to do those bilirubin levels. Okay, and when we look at bilirubin levels, we get two numbers back. We get our total bilirubin, which is all the bilirubin in the body, and then we get our direct bilirubin, which is our conjugated bilirubin. It's already kind of gone through that enzyme process in the liver. Okay, and so one of these numbers is going to be normal. One of these numbers is going to be high. Which number would be high? Which one would be normal? Mm-hmm. Yeah. High. Very good. Very good. Yes. Because the problem here is with that unconjugated bilirubin. Oh, I'm sorry. I just got an alert on my phone saying that there's a snow warning for my area. Um, Connecticut. Yeah. Yeah. Where do you live? Do you have snow? Oh yeah, yeah, you're lucky. Just stay in Jersey. Don't come any farther north, okay? It's hell up here right now. But yes, excellent. So our direct bilirubin is going to be in the normal levels, but because we have a problem conjugating bilirubin, our unconjugated bilirubin would be high. And I didn't give you any number for unconjugated bilirubin. What you have to do is you have to subtract your direct from your total to get the unconjugated bilirubin, right? Yeah. So because unconjugated bilirubin plus direct bilirubin gives us our total level is high, our direct is normal. Very good, excellent. And so the two types of jaundice associated with breastfeeding, we talked about. Breast milk, we have those lipids and proteins in the milk, but our baby is eating well. Breastfeeding, our baby is not feeding enough, and so that decrease in nutrition causes the jaundice. Okay, so our physiologic breast milk jaundice. Prenatally, bilirubin is going to be cleared through the placenta, but postnatally, there's increased production of bilirubin plus decreased hepatic uptake and conjugation. And so, in almost every single baby that's born on the face of this earth, there's going to be some elevation of bilirubin levels. Okay, that is just part of our natural physiologic going through childbirth and coming into the world. We're going to have a little bit of an elevation of bilirubin. Totally normal. Now, when that bilirubin starts to get to a level where your baby's turning yellow, then we can start to kind of name it and give it a title. So for our physiologic jaundice, this is typically seen after the first 72 hours. This is key. This is really going to be one of the things that you look for in getting to your diagnosis. If the baby is 3 days old or older, you think about something physiologic, something benign. Okay? And that's going to be your first way of really determining getting to your diagnosis. It can make the question so easy. If you're able to see that this is after 72 hours, it starts, then you think about physiologic. It's going to peak 3 days after that and resolve over the next 2 weeks, or really resolve after the next 1 week. I should change this. This should say it should really resolve over 1 week. If it's still going on after a whole week period, it should be completely gone after 2 weeks. If it's still going on after that, then we can think of pathology. Okay? Billy is going to... Yes, exactly. Yeah. And so Billy is going to peak at under 15, and we have a large component of unconjugated bilirubin because we can't conjugate it. That's the whole problem. Pathologic jaundice, this is going to be seen right off the bat. Right? The baby comes out, and the baby is already bright yellow. This is going to be persisting beyond a week. It can be high levels of unconjugated, high levels of conjugated, depending on where the enzyme deficiency is. There's like a 6 or 7 step process that converts hemoglobin into the conjugated bilirubin that we excrete through through our stool, right? There's so many steps that can happen, so many places where things can go wrong. And so you can see elevated levels of unconjugated, you can see elevated levels of conjugated. It just sort of depends on where the problem is. The Billy should peak at greater than 15, okay? The worst complication of elevated bilirubin is going to be something called kernicterus, and this is where that bilirubin is starting to get deposited in our central nervous system. The area specifically is the basal ganglia and the limbic system. So when babies start to have this deposition of bilirubin in our central nervous system, we look for lethargy, poor feeding, high-pitched cry, hypertonicity, really flexing, and seizures. Seizures, I think, in terms of our question stems, this is going to be the number one thing to look for, is seizures. Besides the jaundice, obviously. Jaundice may follow a cephalopedal progression going from head to toe as bilirubin levels increase. And typically this requires bilirubin levels of over 20. And so you had asked me earlier, I think I have another slide. Do I? Yes, okay. So this typically requires bilirubin levels of greater than 20. We mentioned earlier, when do we use UV lamps? Typically the cutoff for UV lamps is in the area of 15. Okay, so if we have a baby that has a bilirubin level of 15, then we definitely want to put that baby under the UV lights to sort of decrease the load of unconjugated bilirubin, okay, and allow it to be excreted. So just sort of another chart to break everything down, our physiologic versus pathologic, but this is really everything from the past slide, just kind of putting things next to each other. The one thing, because I'm going to give you these slides, the one thing I really don't want you to worry about memorizing is this particular fact here. Bilirubin increasing how many milligrams per deciliter per day. This is not something that you would need to know for a question. Okay, this is like some really advanced GI stuff. So when I give you these slides, don't worry about memorizing this fact, but I would say everything else on here is pretty fair game. Okay, great. So differential diagnosis for non-physiologic. Now we're talking about pathologic jaundice. What are some of the causes? We can have hemolysis, breakdown of our red blood cells. It could be due to the infant's own antibodies attacking their red blood cells, a genetic condition where red blood cells break down more easily, such as something like sickle cell disease. You can have breakdown of red blood cells. That leads to increase of the hemoglobin in the blood. More hemoglobin in the blood means more bilirubin, because that is what hemoglobin will be broken down into. So those are some of the things we can look for. A patient that is septic may have elevated bilirubin. Hematoma or hemorrhage. Cephalohematoma is when, during childbirth, blood vessel ruptures in the scalp of the baby, either due to using some sort of forceps or tools to extract the baby. You can end up having some damage to some of the vessels in the scalp, and you can have a hematoma or just accumulation of blood in that area. Not a deadly condition, not something we need to cut open and evacuate. That blood is going to be slowly resorbed over the following 2 weeks to 2 months. However, as we're resorbing all of that broken down blood from the hematoma, we may have an increase in the amount of bilirubin in our blood. Okay. Increased enterohepatic circulation, so some sort of bowel obstruction. Decreased clearance. Premature babies are going to have even more premature livers, and so we can maybe see less, clearance of that bilirubin. G6PD is a enzyme deficiency that results in rupture of our red blood cells. And then these enzyme errors that we talked about earlier, in order to go from hemoglobin to unconjugated bilirubin to conjugated bilirubin to stool, there's a number of places where we can have, there's enzymes that are responsible for making each of these steps. And so having a deficiency in any of these enzymes would be an inborn error of metabolism and would result in one of these things increasing, okay, depending on the different ones. Don't worry about memorizing these names. These are just some examples for... Yeah. Don't worry. This is some like gastroenterology, fellowship type stuff, but just, I'm not sure why I even left that in there. I'm going to take it out, but just so you know, those are some possible ways. Could be genetic. Hypothyroidism. So if you have a mother who has some sort of thyroid problem and does not take her thyroid medication, that baby may be born with hypothyroidism as well. Okay. Great. So evaluation and management. First, we're going to start off with a blood smear to look for hemolysis as the cause, destruction of red blood cells. A Coombs test. This is the test that we use for our Rh negative moms, right? Rh incompatibility is where you have a mother whose red blood cells don't have a certain protein on the outside, the rhesus protein. If they're Rh negative, if they lack that protein, and then they conceive with a father who is Rh positive, there's a 50% chance that their baby is also going to be Rh positive. Now, if those Rh positive red blood cells that the mother is, that the Rh positive blood cells of the baby developing in the mom cross over into the mother's blood supply, the mother is going to now recognize those as foreign blood cells, develop antibodies, attack all of those red blood cells. Those antibodies are going to cross the placenta and then attack the red blood cells of the growing fetus, and it can actually be deadly. And so the Coombs test is what we use to look for those antibodies for our Rh negative moms. We can use that exact same test to look for this incompatibility. If there's some antibodies left over in the baby's bloodstream from the mother, that could be a cause of red blood cell breakdown. Okay. Some other, more advanced tests, look for liver function tests, bile acids, a sweat test for our cystic fibrosis. May identify the diagnosis. If we're seeing a jaundice neonate with fever, hypotension, tachypnea, we really need to do a septic workup. Okay, so jaundice plus fever, think about sepsis as a potential cause. We mentioned this maternal fetal incompatibilities. In terms of physiologic jaundice, what we talked about before, breastfeeding moms keep on breastfeeding. That bilirubin level is eventually going to drop as the liver enzymes kind of catch up with the rest of the body in terms of development. The jaundice will go away. However, regardless, whether it's breastfeeding, breast milk, any of these other crazy causes of jaundice, we're going to do that phototherapy anytime it's greater than 15. Okay. As we get close to that 20 number, when we worry about kernicterus, we'll do exchange transfusion where we exchange the baby's blood, take out any of the bilirubin, and then put the blood back in. It's called exchange transfusion, but that would be really a severe thing if we're needing to do that. In general, our treatment is just going to be to put the baby in the UV light. Alrighty. Any questions on neonatal jaundice? I know I kind of covered a lot of information there, but for the most part, just kind of being familiar with the most common causes. I mean, for this exam, you really want to have this mentality of common things are common, right? And so when it comes to a baby who comes in, mother brings in a yellow baby, really the first things that should be popping into your mind are just these physiological causes. Is the baby eating enough? You should be asking how often to feed the baby. And as I'm sure you know from very recently, babies should be fed about every 2 hours when they're newborns. And that goes to 3 hours after about a month or something like that, about that. Yeah. Yeah. And so is the mother maybe feeding the baby every 4 hours instead, and that's the cause of the jaundice? Or is the baby feeding just the perfect amount, and this is just something physiological that's going to go away? Yeah. Great. Okay. So next we have a 4-month-old girl with a history of chronic constipation, failure to thrive, is brought in with a 2-day history of fever to 102, bilious vomiting, decreased oral intake. Parents deny any change in bowel habits from her usual 1 to 2 stools per week. Her only medication is docosate sodium for chronic constipation since 2 months of age. On examination, she has a temperature of 101.4, heart rate of 144, and blood pressure of 95 or 63. Height, weight, and head circumference are all below the 5th percentile. So what do we call this when we have a baby that comes in with height, weight, and head circumference under the 5th percentile? There's like a kind of a buzzwordy name for that. I'll give you the letters for it. FTT. Failure to thrive. Excellent. Physical examination is significant for a thin and tired appearing infant. Abdomen is soft and distended with distant bowel sounds. There is palpable stool in the left lower quadrant. However, on rectal exam, significant for a small ampulla that is empty of stool. We do an x-ray and we see that there's dilated loops of bowel with an absence of rectal air. Okay, so what are some of the things that we think of here with this 4-month-old that's presenting with this chronic constipation? Good. I agree. Especially with this blood pressure, just not looking too hydrated. Tears? Oh, with diapers. Yeah. Yeah. Right. Yeah, I actually would agree with you. I think that when you have loss of skin turgor, you have severe dehydration. And so I also do tutoring for the NCLEX exam, and I've seen questions where they ask the difference between moderate dehydration and severe dehydration. And so some of the earlier signs of dehydration include, decreased diapers, the amount of tears, dry mucous membranes. Exactly. Yeah. So if I were making the question, I would make that the right answer because, if we're losing skin turgor, I mean, babies are plump, right? So if they're losing turgor, that is severe dehydration. Okay. Yeah, no problem. Mm-hmm. Mm-hmm. Yes. Excellent. Very good. Very good. And with this history of chronic constipation, we think about, is this just stool that is just really has now created an obstruction in the colon? And what are some other things that we can think of? If I mentioned that this 4-month-old girl also had Down syndrome, would that point you in the direction of a particular diagnosis? I think I mentioned this briefly when we met last time. I may not have actually. So one of the problems in Down syndrome that we can see, aside from the things we've already talked about, is when patients with Down syndrome, they have facial abnormalities, right? Everybody knows this. They also have heart abnormalities. And the particular part of their heart that is abnormal is something called the endocardial cushion. And that endocardial cushion is what's responsible for giving us the separation between the atria and the ventricles. Okay? And so the reason that we have a problem there and the face is because a certain cell type embryologically is responsible for making those two things. They're called neural crest cells. And patients with Down syndrome, because of the genetic abnormalities, their neural crest cells, they don't function as they normally should. So we see problems in the face with these facial abnormalities because neural crest cells help form the face. We have problems in the heart because neural crest cells help form the heart. In the colon, we have problems with the nerves in the wall of the colon. And so what ends up happening is if we go from the rectum, here's our rectum going up to our descending colon, transverse, and ascending colon. Here's our the other wall. Great. So what happens is neural crest cells start at the start of the colon and then they migrate downwards. In patients with Down syndrome, instead of these neural crest cells migrating all the way down here, they only migrate about halfway. Okay, and so who cares? Why do we need neural crest cells in our colon? Well, they are going to actually make up part of the nerves in the wall of our colon that allow for it to relax. And so patients with Down syndrome have this high risk of developing something called Hirschsprung disease, where Yeah, you're right. So in Hirschsprung's disease, essentially, we have a constriction of the distal colon, the colon that's the closest to the rectum, and we have a dilation of our proximal colon with stool. Okay? And so one of the things that really points us in the direction of Hirschsprung's disease for this particular patient is the fact that the rectum does not have any stool in it. If we had a patient with constipation, typically the rectum would also be distended with stool. But when we see this small size of the rectum and there's no stool there, think about Hirschsprung's disease. Okay, great. And so our gold standard diagnosis is just to take a biopsy of some of that bowel wall and look for the nerves. We're not going to see the nerves, and so that's how we diagnose it for sure. And this thumbs up is just to represent that you are doing an awesome job. This is tough. These patients all present very similarly, so good job to you so far. That one's for you. Yeah, exactly. And they just look so similar, and so we really have to look for those tiny little things to piece them apart, really. And so this is a congenital lack of ganglion cells in the distal colon, leading to uncoordinated peristalsis, and decreased motility is the big part of our clinical picture. Associated with male gender and Down syndrome, these are the ones that we need to know. The ones that we're not going to be asked about, but it's also true, is something called Waardenburg in men too. We don't really need to worry about these ones. Male gender and Down syndrome are going to be the associations, especially Down syndrome, for the AANP exam. Symptoms: failure to pass meconium within 48 hours of birth, bilious vomiting, failure to thrive, and later presentations, usually just chronic constipation. And so seeing that abdominal distension, you may even have an explosive discharge of stool following the direct rectal exam, kind of stimulating things, getting them going, can result in a discharge of stool. We can diagnose this with a barium enema, showing that narrowed distal colon and dilated proximal colon, because all the stool is kind of getting backed up proximally, right? Downstream of that, we don't have the nerves to relax the bowel, and so everything is kind of constricted there, narrowed. Rectal manometry, measuring the pressure in the rectum, is one way of diagnosing it, but the gold standard is just to take a biopsy of the rectum and look for those nerves, and they typically are not going to be there, and so that's how we can really confirm it. To treat this, we would just do an operation to take out any of those zones that don't have nerves. Okay. Any questions on Hirschsprung's? How to make sure that you're identifying it properly? It's pretty straightforward. I think just really looking for, that small rectum, lack of stool there, chronic constipation. Okay. Great. And so here's an image kind of showing what we see. The swollen area behind the constriction are constricted sigmoid colon and rectum due to lack of those nerve cells. Okay, great. Okay, our next case here, we have Daniel, a 11-month-old infant, presents to the office with complaints of watery diarrhea for 1 day. His mother reports that he also had vomiting for a day and fever for 2 days. Maximum temp at home was 102. Has not vomited today, although the fever continues and diarrhea seems to be getting worse. He's had at least 10 diapers with diarrhea since yesterday. No blood or mucus has been noted. She knows another child in the daycare center had diarrhea a few days ago. No one at home has similar symptoms. Yesterday, Daniel completed a course of amoxicillin for otitis media. Daniel's mother states that earlier in this week she began to introduce whole milk into his diet. Review of systems reveals that Daniel has had decreased solid food and soy formula intake since yesterday, has been sleeping more than usual. On exam of the abdomen, hyperactive bowel sounds are present throughout. Daniel has diffuse tenderness on abdominal palpation. His abdomen is mildly distended. No evidence of hepatosplenomegaly. The skin on Daniel's buttocks is mildly erythematous. No diaphoresis. Good skin turgor. Not dehydrated, right? So great. So what is our differential diagnosis? Or if you feel pretty comfortable with what you think is going on. Actually, no. What is our differential here? Because there's a couple different things we can consider. Mm-hmm. 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 Uh-huh. Sure. Sure, absolutely. So some sort of antibiotic side effect versus a viral gastroenteritis. He does have that fever, and so that can definitely stay on a differential too. And then the last thing I'd like you to consider is the fact that we introduced whole milk into the diet this week. And that could be a possible cause of diarrhea as well. Okay, great. So lab testing required for diagnosis. Do we need any lab testing here? If so, what would you want to do? I agree. Yeah. Yeah. Especially, considering the fact that we kind of already have all these causes in mind, and there's nothing that you would test for with any of these causes, really. So great. Lab testing, I wouldn't really do them. What about for treatment? Mm-hmm. Yep. Mm-hmm. Mm-hmm. Right. Yes. Yep. Yep. Excellent. Yeah. Just supportive and, give them a few days to kind of come back to 100%. He's only really been having this diarrhea for 1 day. If the diarrhea had been going on for maybe a week, okay, now we can talk about, let's check this guy's blood pressure. Should we start IV fluids? Is he dehydrated? All that kind of stuff. But otherwise, yeah, otherwise it looks okay. Since we don't have any blood or mucus, we can say that's probably not too serious. Great. So diarrhea, acute diarrhea, we characterize onset of greater than 3 bowel movements per day, lasting less than 14 days. Most common cause there is going to be an infection. Persistent diarrhea, the way that we classify that is any diarrhea for 2 to 4 weeks. Chronic is anything over 4 weeks. Rotavirus is going to be our most common cause of infectious diarrhea worldwide, and there is a vaccine available, which most babies get as a oral vaccine, and that really induces the growth of those IgA antibodies in the lining of our GI tract and kind of fights off that rotavirus. Viral diarrhea is most common in children, especially caused by that rota or adenovirus. But aside from that, we have different categories of diarrhea, which kind of point us in the direction of the cause. If we call it an exudative inflammatory diarrhea, we really think of a bloody diarrhea. So frequent, small volume, bloody stools. And our causes here are some of our nastier of the bacteria, Shigella, Salmonella, E. coli, maybe some sort of inflammatory bowel disease as well as something that we can consider. Probably not in an 11-month-old, right? But definitely things that we can put on our differential possibly. Ischemic colitis. This is a patient with a history of some sort of atherosclerosis, resulting in an obstruction of some of the abdominal vascular supply. A patient with fatty diarrhea, this is probably from fat malabsorption. The most common causes here are going to be our cystic fibrosis and our chronic pancreatitis. I'm just going to put chronic pancreatitis. In cystic fibrosis, we have some damage to our pancreas, which results in not being able to excrete the enzymes we need to absorb fats. And in chronic pancreatitis, it's about the same reason. Okay. For watery diarrhea, this is an osmotic pull, and so giardiasis, laxatives, any kind of lactose intolerant. And secretory diarrhea, here we can have infectious causes, carcinoid syndrome, drugs, as well as our viral causes would fall into this category as well. If we have an acute diarrhea, what kind of lab work do we need? Well, we don't need lab work unless there are red flags. What are our red flags? So a high fever, I'm talking 103, 104, 105, get the laboratory eval. Bloody diarrhea, severe abdominal pain, a patient that's requiring hospitalization, is elderly, some sort of immunocompromised, HIV, or has been on corticosteroids for a long time. These are all areas where we would say, okay, let's just go ahead and do the lab eval anyway. What would that consist of? Well, the stool studies that you mentioned, looking for ova and parasites, C. diff toxin, if our patient has a recent history of being on antibiotics like ours did, C. diff is a possibility. A leukocyte presence in the stool suggests an invasive infection, and that is very severe, something we need to rapidly treat. A pH under 5.5 indicates a viral illness or a lactase deficiency. So seeing that pH under 5.5, this is the oral pH test. where you have your patients take in some milk and then you test the pH of their breath afterwards, and that would suggest a viral illness or lactase deficiency. Culture of the stool, enzyme immunoassay for rotavirus or adenovirus. I mean, this is really uncalled for, right? Whatever we do, it's going to resolve itself after a few days anyway. So typically, enzyme immunoassay will not be necessary. Same thing as the latex agglutination assay for rotavirus, not necessary. We can really just wait this one out. In terms of treatment, in terms of, I guess, rotavirus, we're looking for children in the winter months. Any viral gastritis related to rotavirus, we don't need medications. Antidiarrheal agents, really, we avoid them in children. We don't like to give them. Antibiotics are not really indicated as they may induce diarrhea as a side effect. As bad as that parent is, or as bad as that parent wants antibiotics for their child, we have to sort of educate them that not only do we not need antibiotics for viruses, this antibiotic may give your child more diarrhea, and so we don't want to do that. Hyperosmolar drinks, we think about giving Gatorade to, people with gastroenteritis, but in infants, we really should not be giving them Gatorade. And I mean, this is obvious, right? But I guess I left it in as, so we can talk about the reason, which is hypernatremia. High salt levels can occur if you give a baby Gatorade, okay? We don't want to give, sorry, go ahead. Mm-hmm. Really? Mm-hmm. Exactly, yes. Yeah, you're 100% right. We don't want to give too much plain water either. Pedialyte is wonderful. It has this isoosmolar concentration where instead of drawing fluid in or drawing fluid out or, overloading the baby with fluid, it kind of has this concentration where we're just giving the baby what the baby needs. Glucose, sodium, potassium. So small, frequent feedings is really going to be ideal. This is what we talk about when we say supportive treatment. Rotavirus is very contagious. Family members should practice good hand washing after changing diapers, before preparing meals. And we need to educate those caretakers that the diarrhea may last a full week. So not only are we sending these parents home with no medications, but we're also telling them to wait a week. And so they're probably not going to be too happy, but that's okay. We're still going to get the answer right on our exam. Parent education should also involve what are the signs of dehydration and what to do if you start to see those. Okay, great. And so we have a question here, which I pulled from one of the AANP practice books. The rest of the questions in this slide packet are from that same book. And so this says, which lab value would you expect to be increased in the presence of significant diarrhea? Wonderful. Excellent. Excellent. Yes, very good guess. Go with your gut every time. I'm a chronic answer changer. I don't know if I mentioned this before, but that was something that I really had to work on going into taking my first board exam. There's a reason that you're kind of drawn towards an answer. You learn this at some point and it's buried in there somewhere. And so, this may be its way of coming out. But going after this particular question, the colon's job is to first reabsorb a lot of water. That's the job of the colon. And the second job is to de-acidify anything that's coming in from the small bowel. Okay. So bicarbonate is one of those things that gets released in the colon. If you have significant diarrhea, that means you're going to be releasing a lot of bicarbonate, as well as potassium and sodium. And so our levels of bicarbonate are going to drop. Our levels of serum chloride should look relatively higher. Okay. our patient is dehydrated though, and so they don't actually have a higher amount of chloride. Like if you took every chloride molecule in their body and stacked it up next to every chloride molecule for someone who hasn't been having significant diarrhea, their level would be much lower. However, they're dehydrated, and so when you take a lab value, all you're looking at is the concentration. The concentration is going to be relatively higher. Okay? Great. So, kind of taking this question to the next degree. If you have a patient who's had significant diarrhea, especially for, say, a solid week and a half, 10 days of significant diarrhea, what do you expect the pH status of their blood to be? Excellent. Wait, no, sorry, you said high, right? Not acidic. So, you're right that the stomach is acidic, but and so if you had a patient that was having vomiting for a long period of time, they would be losing that acid and they would become alkalotic. We would have a high pH. But we just said that this patient is losing a lot of bicarbonate, right? From the colon. And so losing all that bicarbonate, what's that going to do to the pH? Make it lower. Yes, excellent. So this patient would have a metabolic acidosis. Yeah, very good. However, if it had been vomiting, that would have been an alkalosis. You would have been right there. Okay? Very good. Yeah, very good. Okay. So let me know what you think of this particular question. Mm-hmm. 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 Yep, excellent. So we have so you're between the psoas and the obturator, right? Excellent. So what is McBurney's? Just so we can rule it out, what would this be? Excellent. Yes. And so the exact, yeah, exactly. So it is a sign of appendicitis. This is the one that's 2/3 of the way from the ASIS to the umbilicus. So the ASIS is that pointy part on your hip bone, right? If you draw a line from there to the umbilicus, 2/3 of the way towards the umbilicus, you push down, you get pain. That's appendicitis. Take them to the OR. Okay, that's our McBurney sign. Great. And then our Rav Singh's sign. What is our Rav Singh's sign? Great. Yep. So that's going to be our referred pain. So we're left with the psoas and obturator. Very, very similar in terms of how we do the maneuver to diagnose it. Our psoas sign, simply with our psoas sign, what we simply do is we have our patient lying flat, lift their leg about 45 degrees. When they lift their leg, that engages the psoas muscle, which is connected from the spine all the way up to the femur. Okay, and so if we have, here's our cecum, here's our inflamed appendix. If we have our patient raise their leg to 45 degrees, I don't know if you can tell what I'm drawing here. I'm such a terrible artist. So here's our hip bone, right? Here's our femur. This is the psoas muscle, and then this is our cecum. This is the appendix, okay? And so what we're doing, exactly, yeah, we're drawing the psoas closer to that inflamed appendix, and that is our psoas sign, okay? However, for this patient, what we did is we flexed the right hip and knee, moving that right leg internally, and that moves it closer to the obturator. And so this is going to be our obturator sign. And I have a picture, yes. So our picture here, we can look at our Ravzig sign. Just like you said very nicely, Ravzig sign is referred pain on the opposite side. Obturator sign, we grab the foot, we grab the knee, and we kind of rotate it. And when we rotate it, we rotate the appendix closer to the obturator, which is the internal side of the hip, sort of the internal side of the pelvis, I should say. Okay? And stretching that particular muscle, we can get that appendicular pain. Exactly, yes. As our patient is raising their leg, we're pushing down, and this psoas muscle, which is connected to the femur, will get closer to where the appendix is kind of hanging here. And that's another sign of your appendicitis. All these maneuvers are great. Really, you're not really going to need to do them, right, in clinical practice, but I suppose that they're good to know for the exam. Okay? Any questions on these? No? Great. Okay, very good. This is fecal oral, and all of these are going to be transmitted through some sort of bodily fluids. Wonderful. Excellent, yes. Hepatitis D actually requires an infection with hepatitis B. Like you can't get hepatitis D by itself. You have to already be infected with hepatitis B to get hepatitis D. Okay, sort of a weird sort of thing there. It is a different virus than hepatitis B. You have to have D to get B, and then you're going to end up with both, which is not good. That is going to be a progression to fulminant hepatitis, where your patient is going to need a liver transplant. But you would never have a hepatitis D infection by itself. You would have a patient with B who then gets D. Very unlucky patient. Okay. For hepatitis E, one thing I didn't mention before, I said that, you're looking for a patient who did some traveling, maybe to, an area with not good sanitation, and you're going to end up with that acute appendicitis. If you have a pregnant woman who gets hepatitis E, she may progress to liver failure. Rather than just having a acute appendicitis, pregnant women who get hepatitis E may end up with liver failure, and that's why hepatitis E is bad. Okay. Great. So, let's move on to our next question here. This should be a pretty easy one for you, considering we just went through this. Wonderful. What would be a sign of peritonitis, by the way, since we have it here? Mm-hmm. Mm-hmm. Yes, you would. Yes, you would. You would have rebound tenderness. Mm-hmm. So peritonitis, is this patient comfortable? This patient is very uncomfortable. So when you think about all of the worst things of abdominal exam that you can see, associate all of them with peritonitis. So your guarding, your abdominal rigidity,